Добрый день, глубоко уважаемые коллеги.
Good afternoon, distinguished colleagues. Good afternoon. Let me welcome all of you after a very tough working day, but this is not our working day. We do proceed. Today we are having a round table, and the topic is modern approach for the treatment of luminal metastatic breast cancer treatments. So, you see our speakers in the agenda, and our chair is Professor Joseph Gligorov, who is the lead of Expert Center for Breast Cancer Studies in Tenon Hospital at Pierre-Marie Curie University, France. So, Joseph, can I invite you to have a seat here? And our moderator for this roundtable, Doctor of Medical Science, Professor of Oncology Chair, Irina Kalyadina. The floor is yours. Probably we do start our meeting not to be delayed, and we're happy to give the floor to Professor Gligorov, the algorithm of decision making in the luminal subtypes of breast cancer. The floor is yours.
Добрый день, спасибо большое. Я буду продолжать по-английски.
Что?
Microphone, it works. You got it? You want me to take the microphone? Okay. So, you can hear me? I have the microphone, but I'm sorry if you can hear me.
No. I think no problem.
Okay, we will go through. So, thanks again. I'm very happy to be here. And I will give a first talk regarding the endocrine treatment strategy in hormone and chemotherapy strategy in hormone receptor HER2-negative metastatic breast cancers. And I will just begin with what is the historical and epidemiological point of view. You probably know this very old publication just showing what is the natural history of breast cancer, and regardless of the metastasis or not the patient had. This is natural expectancy, overall survival expectancy that you might have. And when you compare it with what are the survival and natural survival of the population at that moment, you see that clearly it was a terrible disease. This is just to have a kind of point to compare what we know actually when we look at the evolution of the overall survival in metastatic setting. This was provided by the Swedish colleagues. When you look at the evolution of the overall survival among different class of ages of population during the last, I will say, 35 years. And we have provided pretty the same information in France with a very interesting observatory that we have called ESME, and we will discuss in the second point about that and eribulin. But this is just what happens regarding the overall survival of patients with metastatic breast cancer in France, looking at the period of 2008-2013. And when you look at the results, you can see that there is not too much differences for the triple negative. We have moved from 15 months to 14 months, so exactly the same. Not a lot for the hormone receptor positive, pretty close to 40 months. And the biggest progresses that we have made was initially in HER2 positive disease. And interestingly, when you look at the hormone receptor positive HER2 negative population on the right side, what you can see is that it seems that the last, let's say, 15 years, we don't have any signal of overall survival improvement. But the second point is that when you look at the subgroup that might differentiate this population to the other one, is that the presence of visceral metastasis is clearly one of the key prognostic parameters in this population. Back to this historical perspective, I just want to remind you what are actually the statements regarding the treatment strategy we might apply in this population. According to the ESMO ABC guidelines, we have stated that for this patient, endocrine treatment is clearly the preferred option out of the situation of the visceral crisis. And the second thing regarding the international, let's say North American guidelines, the NCCN, it's exactly the same. So worldwide, all the experts have stated that we need to begin theoretically in patients with hormone receptor positive disease with endocrine treatment strategies, and maybe just look at the chemotherapy in case of the visceral crisis. However, what is interesting is when you look what happens in the real life. This is also a French registry that have shown that when you look at the patients that have been treated in metastatic setting, the same result that I showed to you before, 42 months of median overall survival in this population. When you look what happens in the further line, if 100% of the patient receive endocrine treatment in the first line, this was a selection criteria for this analysis, just half of them received the second line endocrine treatment, and about 80% of them do not receive a third line endocrine treatment. That means that in real life, there is a poor adherence to treatment guidelines with potentially an inappropriate high use of chemotherapy. And this is what we have also looked when we look at the different studies that have shown the adherence to the treatment. And you see that if the majority of the oncologists will widely use endocrine treatment in first line, in the majority of the case, they will switch pretty fastly to chemotherapy in further line of treatments. So the first point is that hormone receptor HER2 negative metastatic breast cancer is the most frequent population that we have to treat in metastatic setting. We do not have clear signals that we have improved overall survival in this population with endocrine treatment alone. Despite the guidelines, real-life data are showing that treatment strategies are more divided in this population between endocrine and chemotherapy approaches. And all that I've said to you, you have to consider that this is an historical point of view. We have not yet integrated the importance of the CDK4/6 inhibitors in the metastatic breast cancer treatments in this population. So then, let's look at what we have regarding the chemotherapy in this population. And the point is that when you look at all the retrospective data, we have a modest benefit of single-agent chemotherapy for advanced breast cancer. This is what we have stated regarding different overview and different review of database. But we have to be careful. First, all these data are usually retrospective data, using different treatment regimen. They are all looking at monotherapy, but we have also results with polychemotherapy that had more benefits regarding the disease control. Different types of... It's a huge difference between chemotherapy and endocrine treatment is sometimes that when you initiate endocrine treatment, you will prolong this delivery of treatment, and regardless of the fact that you will do not have, let's say, a response, if you have a maintenance treatment in the disease control, you will continue. That will be not the case with chemotherapy due to toxicity profiles. Other thing that we have are retrospective comparisons between chemotherapy at first-line treatment in hormone receptor positive HER2 negative population, comparing with, let's say, endocrine treatment, which was a classical endocrine treatment without any modulators. And this Italian study, published in Annals of Oncology last year, showed that it could even be detrimental, but you have again to be very careful because it's different type of patient, no maintenance treatments, and this is not a randomized trial addressing the question in aggressive disease or not aggressive disease. So you have to be very careful about that. What I want to focus now in the next few slides is what we have presented at San Antonio last winter. The paper is under review, and this was a French trial that François Clément Bida, which is a friend of mine, have initiated in France. We have participated a lot of centers in this trial, addressing the question of, is it better to begin with chemotherapy or to begin with endocrine treatment in case of metastatic breast cancer situation. And we have addressed the question of a potential biological tool that might help to take the decision. And the potential biological tool was the circulating tumor cells. So the patient were randomized between two possibilities. One, clinician choice. You as a clinician will decide if you consider that you are in a low-risk situation or in a high-risk situation, and you will decide the treatment. Low mean endocrine treatment, high mean chemotherapy. And for all the patients, they have a count of CTC. But half of the population do not have the results at the time when the clinician choose, and half of the population have the result at that moment. And then we split this population in two, and the second one received a treatment strategy driven by the count of CTC. If you have a low rate, endocrine treatment. If you have a high rate, chemotherapy. The primary endpoint was to just look at the PFS non-inferiority between the clinically driven and CTC-driven arms. And the different secondary endpoints are looking at the overall survival and the progression-free survival. We've included close to 800 patients in 70 centers. And here you have the patient characteristics according to the different arms. The control arm on the middle, when you have taken the decision just using clinical criteria, and the right arm, the CTC arm on the right side, when you take the decision according to the CTC count. And you see that the rate of concordance is pretty good regarding the clinical low and CTC low, and same thing regarding the clinical high and CTC high. And the discordances are here on the middle when you look at the clinical low with CTC high or clinical high with CTC low. Then the primary endpoint was clearly here and with concluent results that you might use CTC or clinical judgment. It will give you the same information regarding the way you might have an estimation of the PFS. But then we have looked at the overall survival, no differences, same thing. And we have looked at the different groups. If you judge as a clinician that the patient do well and you use endocrine treatment and the CTC are low, these are what you might expect regarding the PFS, 1.5 years, 18 months, and the overall survival rate at 24 months is more than 80%. If you look here at the clinical high, aggressive disease, you have judged as the aggressive disease, and you have also a high rate of CTC, you see the PFS, which is close to 1 year, and the overall survival here. But the patient have all been treated with chemotherapy. Here is an optimal situation when you have the two information. Let's look now what information we have with the CTC in case of discordancy. Here are the patients that are clinically low but with high rate of CTC, circulating tumor cell, and here are the patients that are considered to be high risk but with a low account of CTC. And here you have in red the chemotherapy arm and in green the endocrine treatment. And interestingly, in both situations, chemotherapy do better than the classical endocrine treatment. Of course, you have maintenance treatment with endocrine treatment after, but the point is that we could not judge, to be very, very clear, that the clinical estimation is good. Here the p-value is positive in favor of chemotherapy. The only situation when sometimes you might desescalate, because there is no difference, statistically difference, is when you have clinically that seems to be high risk, but CTC low, which is really interesting. And in an exploratory analysis, if we put together all the discrepancies between clinical judgment and biological one, it's better for chemotherapy when you look at the PFS, and there is a small signal also for the OS when you look at the chemotherapy. So when your clinical judgment is not very sharp, I will say, regarding the situation, maybe it's more interesting to use chemotherapy. And this has a different median PFS that we have observed in the clinical trial. So what happens in real practice? In fact, you have different parameters that might help you to take, I will say, decisions regarding endocrine or chemotherapy. asymptomatic, more luminal A, indolent, long-term survival. These are the population that you will probably treat with endocrine treatment first. And these are more maybe the population when you will consider, of course, using chemotherapy. And the different parameters that you will use comparing endocrine and chemotherapy are factors associated with the disease, but also sometimes factors that are associated with the patients, according to the age, the menopausal status, the socioeconomic and psychosocial factors, and of course the availability of the different drugs you might have. So the second step is that chemotherapy versus endocrine therapy trials are rare and are all retrospective data with multiple bias. Treatment decision for the choice might be driven by clinical and or biological parameters. The clinical parameters are useful to better identify disease aggressiveness, but adding biological parameters might be clearly interesting, and the integration of the new endocrine modulators like CDK4/6 and PIK3CA inhibitors might change our global strategy in the near future. So very quickly, my last part is what about the new endocrine strategy in this situation and potentially the role of chemotherapy, and why we're discussing that. In 2 weeks, we will have the ABC5 when we will discuss what will be potentially the new standard of care. But already in ABC4, 2 years before, it was stated that one of the preferred treatment options might be the CDK4/6 inhibitors up front. These are the 3 CDK4/6 inhibitors that we have actually in clinics: abemaciclib, palbociclib, and ribociclib. The results regarding the primary PFS are quite similar, and regardless of the drug, and quite similar for the second line when you look at the hazard ratio and the differences between the arms. That is mostly driven, when you look at the control arms, by the fact that you will use more endocrine or more or more endocrine resistant population in this second line. What makes the difference is more clearly the profile of the toxicity among the different drugs. But there is one trial that have addressed the question of comparing CDK4/6 inhibitors in very young population to chemotherapy. This one was a young Pearl, palbo, exemestane, and LHRH agonists versus capecitabine, which is not potentially the best option that we might discuss. They have concluded that the population was pretty well balanced when you look here, and when you look at the different treatment that the patient have received before, they were in a pretty good condition with a low treatment, and they conclude that the PFS was better when you use palbo, exemestane, and agonists comparing to capecitabine, which was in the limit of significance. But the fact is that you have to focus on the visceral mets that we don't have here. We have some data that have been reported with ribociclib, when you see here, and also with abemaciclib regarding the different Mona Lisa trial. And when you look at the hazard ratio, they are pretty the same comparing the patient with visceral mets and non-visceral mets. But there is clearly a tendency that the median PFS is not exactly the same. One of the recent meta-analyses, which is really complex, it's a difficult paper to read, to be honest, in Lancet Oncology. This was published 2 months ago or something like that. Indirect comparison, again, versus endocrine treatment and chemotherapy. It's not a true meta-analysis, but the conclusion is that actually with the CDK4/6 inhibitors, we have a higher rate of response comparable to the best chemotherapy option we have before. But just to remind you, this was the case also when you look at the Bolero-2 trial with everolimus at the beginning. Very impressive PFS, no difference in OS. And one of the comments of Gabriel Ortobaghi in Annals of Oncology was at that moment that potentially the control arm who do not receive everolimus receive more chemotherapy, explaining that we have this clear absence of difference regarding the OS. Same thing for the new approaches regarding the endocrine resistance, just to mention that, and my colleagues will probably focus on different topics regarding the resistance, that we have the future maybe with the PIK3CA mutations, identification of patient and using of alpelisib in this situation, and that at the end, The guidelines are still the same, but we have to clearly define what is a visceral crisis. And I just want to remind you the definition that we have stated in ABC2. We will discuss again this definition in 2 weeks. But it was not due to biological parameter, but to clinical one. The situation where you think that if you don't control the disease in the first line, you will not have other options to give to the patient after progression because of the aggressiveness of the disease. The primary endocrine and the secondary endocrine resistance, that will be also discussed. And what we can offer after progression, and of course we can offer different approaches like chemotherapy, which is still a valid option in endocrine, in estrogen receptor positive population, even if it's not upfront. And this makes the situation more complex if you integrate the endocrine sensitivity here and the type of different visceral mets or absence of visceral mets, then you can modulate and potentially find the way we treat the patient in everyday practice. So my last slide is that all guidelines recommend to use endocrine treatment strategy up front in absence of visceral crisis, and CDK4/6 inhibitors are the new standards of care in this situation. However, the treatment strategy choice depends on clinical biological parameters, sensitivity to previous endocrine treatment, exposure to this treatment, possible predictive factors, treatment choice, patient choice, and survival benefit is a global benefit from the different strategies we might apply in different lines. So I will be more than happy that you will join us at the ABC5, and thank you for your attention.
Thank you so much for a nice presentation. У кого-нибудь вопросы есть?
Any questions, comments, remarks? You're welcome. You're welcome. Any questions, comments, remarks? Well, possibly the questions will come later on because we just start, and that was a very good educational presentation from the leading expert, global expert from France. No questions? No, I have no questions. Yes, I think we will discuss the questions, cases, and we will have questions later. Thank you very much. So the next presentation on hormone resistance instead of the place of chemotherapy in CDK4/6. Kaledina Irina, Doctor of Medical Science, Professor of Blokhin Research Center. Yes, absolutely right, absolutely right. But I cannot see anybody. Well, hopefully you can see upper part of my face, but the most important, you can hear what I'm going to talk about. In fact, my presentation, it's a continuation. Ребят. I think it's very important to understand the mechanisms of hormonal resistance. And today I will try to open some secrets to you. Техник, подойдите к переводчику, пожалуйста. Техник может подойти к переводчику? Well, the treatment of the metastatic hormonal positive breast cancer is very relevant, and no argument about that. Техник может подойти к переводчику? Техник слышит или нет? Или он глухой? Сидят. Питерский подход. So in the prevalent stages, it is different. So in the prevalent stages, we see that half of the patients have hormonal positive subtype of the disease.
8% в нашей стране имеют 4-ю стадию, посчитайте, половина из них это где-то 4% пациентов всего, да? А вот рецидивирующий рак имеет гораздо больше количество.
Relapsing cancer has many more patients. That's why this is a problem. Why patients do relapse, although there is very good treatment, although we already try to treat earlier cancer much better. Почему такое эхо сильное? So why there is such a relapse of the disease? So we will try to talk about it. The hormonal treatment is a lot in luminal cancers, and there is no argument on that. In planning, we definitely take into consideration the status, the previous treatments, and relapse-free interval, its duration less than 1 year or more than 1 year, and chemotherapy in luminal cancer. And we know that we administer it in the visceral crisis, спасибо, or in hormone-resistant tumor. And for hormonal resistance currently, there are very clear criteria when we say that the tumor potentially hormonal sensitive. Well, first, all hormonal positive tumors, HR plus tumors that contain at least 1% of estrogen receptors or more before the start of treatment. So here it can be earlier stages or primary disseminated process. So before the treatment, all of them are hormonal sensitive. If the patients progress on the treatment, then they become hormone resistant. How do they have to progress to call them HR resistant? Well, they progress either with adjuvant treatment or within the first year after the end. So this is the criteria of hormone resistance. And if early during first 2 years, so this is primary hormone resistance, which is called hormone refractory. So if after 2 years, well, first 2 years of adjuvant and everything is okay, and then there is a progression, then this is secondary HR resistance, but less than 1 year after the end of adjuvant. If this 1 year already passed and then the patient progresses later than 1 year, so that she's potentially hormonal sensitive. If we're speaking about metastatic breast cancer, so progression within the first 6 months of treatment is a feature of primary HR resistance. If 6 months without relapse and disease is controlled and there is no progression, then it's secondary HR resistance. The second factor we take into consideration, this is definitely visceral crisis, because it's not equal to visceral metastasis, and I'm pretty sure you know the difference. And definitely we take into consideration menstrual status, because if you look at the old guidelines, so the first thing what we need in the patients with progression of the disease and with primary disseminated process that you are planning any hormonal treatment is switch off ovaries, either drug way or surgical way, because in the premenopausal status almost no options to treat, only tamoxifen, and we'll speak about it later on. And what is menopausal criteria? Well, this is a standard criteria. Please remember that the absence of menses, no menstruation with chemotherapy or after that, is not the criteria of menopause. All the patients younger than 60 who are not surgically resected will have to confirm menopausal status biochemically, and it should be FSH and estradiol, which are confirming that. Why is it so important? Because with aromatase inhibitors, with ovarian suppression, it appears to be that we managed to reach menopausal stage, not in all the patients. And yes, such data was presented quite recently. This is combined analysis of 2 large randomized studies. This is you know these studies, so when the patients text and soft, when the premenopausal patients in this group, with the risks of involvement of lymph nodes, they received either tamoxifen with ovarian suppression or aromatase inhibitor. In soft study, there was a control group as well that received just tamoxifen as a mono. In primary analysis, these patients demonstrated that yes, in the risk group, ovarian suppression plus aromatase inhibitors is better because it reduces the risk of relapse by 34% and increases in absolute number by plus 4% the relapse-free survival. Although initially in this analysis there were different types of surgical ovarian suppression, including surgery, castration, and drug castration. But when they selected a subgroup of females that had drug castration, which is gazelurine, and they were analyzed separately, it appeared to be that the estradiol level in the blood was much lower in those patients who had tamoxifen. And in 2/3 of females periodically observed some ups and downs of estradiol with gazelurine injections. So in every 3rd patient, these ups and downs at least once went beyond menopausal range, and in every 6th patient, menopause never happened during the whole course of treatment. So we started thinking over, who are these females? It appeared to be these are females younger than 35 who never received chemotherapy, and mainly patients who are overweight. What happened next to them? So they were analyzed separately. It appeared to be that females who were receiving aromatase inhibitors with ovarian suppression by drugs, gazelurine, the mortality risk is higher by 31% versus the ones who reached menopausal stage. And 8-year survival appeared to be much better relapse-free and overall survival, because for aromatase inhibitors they gave advantage just in relapse-free survival, so for patients who received tamoxifen and ovarian suppression. That's why the authors concluded that we need to control the estradiol level in patients who are receiving endocrine treatment by aromatase inhibitors with ovarian suppression. Suppression should be confirmed. You have to be absolutely sure that the patient is in menopausal. So if you don't control and patient progresses after that, so the first question you have to ask, did you reach menopausal status or not? Did you reach it at the stage of adjuvant treatment with gazelurine? Because it could be the reason of that hormonal resistance. The second factor, which is actively discussed all over the world, this is low expression of estrogen receptors. And if you appreciate the latest guidelines, so there is even a special group here, because, well, here NCCN 3 groups, and in fact German guidelines also 3 groups, which are sensitive more than 10% of the cells, so or progesterone, estrogen or progesterone, or truly non-sensitive and doubtful sensitive from 1 to 9%. And if you appreciate the latest NCCN guidelines, so here small font. I love reading small fonts always. Biological characteristics of breast cancer with low HR expression, less than 10%, closer to hormonal negative breast cancer, and it should be taken into consideration when you select adjuvant strategy. And last 2 years, so lots of studies like mushrooms after the rain, and they show us that the prognosis of patients with luminal HER2-negative cancer directly linked to the estrogen receptor expression. So if it's high, then 5-year survival, definitely higher than 90%. But if it's low expression, and this study was presented back in 2017, then by 5 years of follow-up, we see survival rate much lower, which is at least 50% or maybe lower. And the latest data by ESMO, this is prognosis of patients and response to chemotherapy with low expression of estrogen receptors, which is close to hormone negative. Close to hormone negative. Here is response to neoadjuvant. You know, this is at the same level of the marker, and the risk is the same like in triple negative. And there is now a position, so possibly in the clinical trials on triple negative, we need to include these patients who have up to 10%, where estrogen receptors expression is very low, because it reminds us triple negative. For those patients where expression is higher, well, definitely endocrine treatment is the main option of treatment, and biologically it's clearly justified, because we have clear mechanisms, block of estrogen-dependent pathway, we have some additional mechanisms, block of pathways that included, let's say, in the block of the main way, let's say, alternative regimens, and here they are. But the main point here is that if you just imagine estrogen pathway as the running line where there are particular checkpoints. So first checkpoint is estradiol, estrogen, which is running to estrogen receptor, and just to it, then excited receptor is coming to the nucleus, and then in the nucleus it surges. Final point, which is CDK, which starts cell cycle. So we can block it when we neutralize each of the runners, when we prevent first delivery of estrogen receptors and the effect. So we can influence estrogen receptors, we can influence estrogen to block the third runner as well, to neutralize the third mechanism. And we have a number of drugs that can work as a mono, and also the ones that are used for the combined treatment, which influences all these mediated pathways. So tamoxifen was historically the first one. I love it. Yes, this is a drug with 50-year-old evidence-based data. The efficacy proved in the randomized trials. This is the only one which demonstrated its effect for the prevention and for the treatment of breast cancer. This is a drug which has, in fact, probably best ratio of cost efficiency, so very cheap but very effective. But unfortunately, for the patients with metastatic cancer, it's too weak. It's too weak, because normally it was already used in the adjuvant treatment, and then the efficacy is not high enough. So what is our hope? Well, 6 months progression-free survival, and about 3 months, well, up to 2.5 years overall survival. Well, definitely we want to see different figures, and yet nothing else is designed. For example, there are trials for new options, different derivatives of tamoxifen, which are studied, different metabolites with anti-tumor activity. Even they try to synthesize derivatives of tamoxifen, which would have lower adverse event rate and fewer adverse events. treatments that will probably allow us to increase doses of these tamoxifen derivatives. But yet, these are future plans. But now we have the other class of drugs, which is aromatase inhibitors that block estradiol delivery to the receptors because they reduce the level of estrogen formation. And in patients in pre- and postmenopausal, it happens during pathways in different organs. If it's premenopausal, so that's mainly ovaries, and estrogens are formed from testosterone, and if it's postmenopausal, then this is fat tissue, and this is estrogendiol, this is estrone, the other hormone. And we can block both pathways if we use aromatase inhibitors or aromatase inactivators, specifically exemestane. But we have to remember that in menopausal patients, immediately the feedback is launched through CNS. This is reduced level of estrogen receptors. It leads to additional stimulation and restart of the ovaries. So never ever in these patients, we never give aromatase inhibitors in premenopausal females without ovarian suppression. What are our hopes for aromatase inhibitors? Well, better progression-free survival months, about 9 to 15 months. And in the recent studies, if we appreciate the control group here, which in the studies devoted to the combination of CDK4/6 inhibitors with aromatase inhibitors, we can appreciate, in fact, the same 14 to 16 months, and the objective response rates of about 35–40%. Well, the third option that we can use as a mono, which is also working, which is fulvestrant. Of course, it's different from tamoxifen because tamoxifen blocks just one transcription end of the receptor, but fulvestrant blocks both of them. That's why the mechanisms of additional stimulation of estrogen receptors completely downregulated, and when it links to the receptor becomes unstable and degraded. And it has very important protection from hormonal resistance, which later on will be remembered. I will come to that later. So efficacy of fulvestrant is higher versus aromatase inhibitors, and it has been shown in several studies, but not for all the patients, only for the patients with non-visceral metastasis. And in this situation, we see, well, not bad figures of progression-free survival, which is 22 versus 14 months, so absolute gain is almost 9 months. But for the patients with visceral metastasis, unfortunately, there is no gain both in PFS and the OS. In fulvestrant monotherapy, we do not see it. We don't see any advantages. And if it's already developed HR resistance, that means second line of endocrine treatment, so the levels are much lower. So objective response rate is 6 to 12, so single studies show plenty, and median of progression-free survival maximum up to 1 year. So the question is why? Why? We have such good molecules and suddenly they stop working. Why it happens? So the mechanism of hormone resistance is actively studied now, and only a lazy person did not hear about estrogen receptors, about mutations in estrogen receptors type 1, which is ECR1. This is estrogen receptor type 1. So what is that? Chromosome 6. This is gene that regulates the level of estrogen receptors in tumor cell. So not only in the tumor cell, in healthy cell as well. So if this gene is mutated, then there is a situation that leads to the continuous stimulation of the receptor. So they don't need any cofactors for stimulation, and this cell can escape endocrine treatment. It can get rid of anti-tumor response and actually become hormonal resistance. What is interesting to see in this case, in early cancers, in non-metastatic stages, mutations of estrogen receptors, they never happen, just 3% in early stages. But in case of metastatic stages, the mutation rate is increased up to 50%. And mutation can be found almost in all the organs, including bones, liver, lungs, lymph nodes. Well, dominating 3 types of mutations, and the recent data, which by the way was presented at ESMO, tell us that about 20% of the patients with metastatic breast cancer have at least one mutation of ESR gene, and 30% more have multiple mutations of ESR1, and this is important prognostically. So now we can appreciate that fulvestrant can become the drug of choice if there is a mutation, because for this drug it's not so critical that there is ESR mutation, because it destroys the receptor, completely blocks it, and possibly Secondly, it is an option of choice in the availability in the case of mutated patients. At least there are such trials carried out. The final point here is CDK, which is cyclin-dependent kinase. This is final runner in our marathon, which I talked to you about transmission of the key signals. So we know that now there are already 7 trials that show, well, pretty similar level of efficacy, which is Paloma, Mona Lisa, and Monarch. So from up to 27.5 months in Mona Lisa 7, and latest data that was presented at ESMO, already 33 months for the combination with fulvestrant in first line. If we speak about ribociclib plus fulvestrant in the second line, of course a bit more moderate result, but also better than monotherapy. And last but not least, now we know that this is not just progression-free survival benefit, but now it's overall survival benefit for 2 CDK4/6 inhibitors. It has already been proved for ribociclib and abemaciclib, so we are waiting for palbociclib data. I hope it will be identical because the class is the same. The class is the same with the same mode of action. And what is interesting to see here for CDK4/6 inhibitors, the half expression, please appreciate it. This is subgroup analysis. Even half expression level is not a problem. So the drug can manage this expression when receptor estrogen are truly positive but progesterone 0. But the question is, would they work at low expression when it's very low, less than 10%? That's another story. What is typical for CDK4/6? This is class effect. So very fast response, very fast splitting of the curves, very good gain, but unfortunately during the first year of combined treatment, every 5th patient, although there is good result, there is a progression. There is a progression, then the question is why? Why, even in this group, we do have patients who progress, and what to do next? In fact, what to do, nobody knows. There are different positions, there are different trials that are carried out currently. So the first option, we keep CDK4/6 inhibitor the same and we change endocrine partner. The second one, we keep endocrine partner and we switch CDK4/6 to the other one, because now there are 3 of them. And the third option, we keep both and we add on something else. And all the trials which are carried out on the hormonal treatment mainly are ruling about these 3 options. So there are even triplets when we switch hormonal treatments, let's say post-aromatase inhibitors to fulvestrant, and we take CDK4/6 the same. And those patients who already had aromatase inhibitors and fulvestrant, we switch to a combination of everolimus plus exomiston, but we keep CDK4 there on board. And the first results already published. What is better? What is better? Well, at least this is very small but very interesting study which was presented by Mayo Clinic that included 369 patients with metastatic breast cancer received CDK4/6 inhibitors at Mayo Rochester, and then there was a progression. And then patients received either monotherapy cytostatics, either monotherapy by hormones, or endocrine agent was changed, and there was treatment of CDK4I, everolimus plus exonestan. It appeared to be that to keep CDK4 and switch endocrine agent is more prospective than to complete a switch and to give, let's say, monotherapy of chemo or mono of endocrine. But again, this is quite small, quite small study, maybe something is not quite representative. This is single-center study, so it cannot be considered as a very solid data, but, well, at least we have some first ideas. So this is a reason of acquired hormonal resistance, because initially the tumor does not have any expression and it does not have any mutations in the gene of estrogenic receptors, but later on it's looking for a mechanism to escape. And this is how the mutation is fixed there, and then this clone is surviving. Well, there are mechanisms of congenital hormonal resistance, and such mechanisms are known. These are mutations in the signal pathways which lead to activation of estrogen-dependent signal pathways, specifically PI3K signaling pathway. And there are 2 drugs that we are currently using and which are available. This is the second player on the market. This is everolimus, and well, everolimus has already been mentioned because it showed very good results of progression-free survival, but unfortunately without gain of overall survival. But still, this is quite good. It can be a good partner in combination to fulvestrant. It could be a good combination partner to tamoxifen, and in all three studies with fulvestrant, with tamoxifen, and with aromatase inhibitors, exemestane here. So it was quite good gain of PFS. That's why global guidelines, EBC4, recommended this combination with any endocrine partner. It was included here, and it was taken into consideration. That's interesting. And what about these mutations? ECR1 mutation. Will everolimus work here? Yes, and such studies were carried out as well. It appeared to be that benefit is for non-mutated patients. And plus to that, if there is no mutation, that's the best thing. This is a gray curve on the right. But if there are two mutations, double mutations, then overall survival is really devastating. If you look at absolute figures, it's almost twice shorter versus patients who are wild type. That means that even in this situation, even combined hormonal treatment, exemestane plus everolimus, may not manage if there is this double MT. But what if we give CDK4/6 to this combination? Would that help us to overcome mutations, triplets? And ASCO this year presented very first results, which is Trinity 1. And here are the patients who already progressed for CDK4/6 inhibitors in the first or second line, then received CDK4/6 as well, ribociclib, everolimus, and exemestane. Well, at first results look not bad. Progression-free survival is about 6 months, but it appeared to be, in case of mutation, ECR1 mutation, it would be just 3.5 months. Then the question, well, if it develops, should we continue our experiments with hormonal treatment? Maybe. In case of mutation, yet we do not have targeted agent here. Maybe these patients should switch immediately to chemo. And we have another mechanism which potentially we can block in patients. So actually block the first primary point, which is PI3K signal pathway, and this molecule is also available. This is SOLAR-1 study. Patients who progress on hormone treatment in case of PI3K mutations. This is second line of treatment. Alpelisib plus fulvestrant increase survival and median of progression-free survival. Please appreciate, even in those patients who received in the second line, I think it's even more valuable than the first line. And the gain was almost for all the subgroups, but unfortunately, we don't know whether there were any patients with ECR1 mutations. Yes, this option is available. This option, alpelisib, is there. It's included there. And when we speak about hormonal treatment, hormonal positive tumors, no visceral crisis, should go to hormonal positive tumors, they should get endocrine treatment, and patients should get it sequentially if visceral crisis is not developed in case of hormone resistance or resistance to 3 consecutive lines of treatment. Only then we can think about switch to chemo if a clinical situation requires that. And these are our practical guidelines. So keeping in mind of what I said before, it seems to me that indication to switch patient to chemo in hormonal positive cancer, possibly not only the visceral crisis and not just hormonal resistance of the tumor, but possibly we should think about the low expression of estrogen receptors, where we can have triple negative-like behavior. So we don't have the data that CDK4/6 would work with a lower level of estrogen receptors. We have the data that in the half-half, when there is estro but no progesterone, or vice versa. And then until we don't have targeted mutation, target. So that's my personal position. What to do next? Any hopes for chemo? So this year, a very interesting study was presented. This is an American study. It was presented in Miami, Florida. So this is real practice of United States. Patients who, since 2015 up to 2017, were receiving as a first or second line CDK4/6 inhibitors. Most frequently, that was palbociclib, because it was very available at that time in the United States. And after progression, they were switched to eribulin. So in that study, there were 4 groups. Group 1 that received eribulin upon indications. That means they had to have anthracyclines and taxanes as a first or second line, and at least 1 line because of metastatic cancer. Patients who received a 3rd line eribulin, that means into previous, they already had CDK4/6. That means they have fewer options of chemotherapy. Patients who received eribulin as a 2nd line of treatment immediately after CDK4/6 4/6 inhibitors and the patients who received eribulin in a later lines, which is line 4 or further. So this is very fresh data, but very interesting, very juicy data, fresh and juicy, because it started in December 2017 and the first results were counted 9 months 6 in September 2018. So this is newborn baby, 9-month baby, but in this study, 64% of patients had stage 4 primary disseminated tumor. 90% of the patients had visceral metastasis, including lung involvement, liver involvement, and even brain involvement. They took different factors, including the quality of the medical insurance, because it appears to be in America it's a factor that matters, matters for the results of the treatments. Well, within the first 9 months, 1/3 discontinued, 2/3 continued, and almost in half of the cases that discontinued from eribulin, the reason was progression, very clear progression. But other 50, if you appreciate it here, just 4% because of toxicity, and the rest, it's either decision of the patient or maybe some problems with insurance, etc. If we appreciate the first results of the efficacy data, median of progression-free survival currently is 10.26 months. And this is longer than all lines of endocrine treatment after CDK4/6 inhibitors. It's longer. It's even longer than eribulin itself in the standard indication, because we used to see this 6 to 8, 5.5 months, 6.8, 5.5 months. Yes, these are just first 9 months of treatment, but this is very interesting. If you look at the subgroups who were receiving in earlier lines or in the later lines, so these 10 months, these are exactly the patients who received it upon indications or as a second line of treatment right after CDK4 inhibitors. But if it's a later line, then just 4 months. So what happens there? Why patients respond after CDK4/6 inhibitors so nicely to eribulin, yet not clear? But in any situation, this option can become quite competitive if there is a confirmation in other clinical trials, different clinical trials. So summing up, I would like to say, yes, hormonal positive, HER2-negative, most multiple luminal HER2-negative cancer, where endocrine treatment currently is a leading instrument in this orchestra. The main breakthrough in the treatment of our patients is related to combined regimens of CDK4 inhibitors with partners. But hormonal resistance is a real challenge, and it can be congenital, as I showed before, related to PI3K mutation, or it can be acquired when the tumor starts expressing mutated estrogen receptor genes to escape, to get rid of the treatment, to avoid apoptosis. And this resistance has a very deep molecular and genetic mechanism that we just started learning. Now, please recollect that acquired hormonal resistance, and this data, by the way, was recently also shown, so patients with potential hormonal sensitive tumors before the treatment and then after the treatment, 6 months later, they start accumulating mutations. So, in fact, it can lead to real resistance to treatment. And we don't know the solution, what to do after CDK4/6 inhibitors. We understand that we can continue endocrine treatment up to the 3 lines, because if the patient has no visceral crisis, but what to do, what to select, what to choose, we don't know. First results on eribulin and American study gives us hope that possibly it can be a very good competitive option. Thank you very much for your attention. Thank you very much, Irina. Any questions? You're welcome. Any questions? Joseph? Questions? With microphone, please, because I'm totally deaf today.
Yes, very nice presentation. My question was more devoted to potentially your practice, but maybe we'll discuss with clinical cases. Are you using upfront endocrine treatment also comparing to chemotherapy, or you're taking into account, you're searching mutation like ESR1 mutation or other things routinely?
Вы нам по-русски говорите, чтобы переводили тут, а Джозефу переведут, translate.
Well, I think the switch from hormone treatment to chemotherapy, I think we can better discuss it in the clinical cases when we discuss the cases specifically, because specifically to each case, I think there is no universal prescription. I think there is no universal solution. We have to take into consideration multiple factors. I think it's a good opportunity today to discuss for each case specifically different potential options. What would you do and what we do? Yeah, because we have different scenarios. I think it can be interesting, right? What do you think? Right? Oh, yes, right. Irina, I have another question to ask. So this is a study, you said very fresh and very juicy American one. Didn't they have group with other chemo drugs? I mean, did they study the efficacy of other chemotherapeutical options after CDK4/6? So why specifically Ribulin was selected? Well, the ones who received Ribulin in these patients, they had anthracyclines and taxanes. They were pretreated before. And the patients progressed on anthracycline and taxane, so they reached Ribulin. Those patients who did not progress and they continued getting anthracyclines and taxanes, they continued, and they were not counted because the control group, so other monocytostatics were not selected. So the main task was there to understand what is the place of Ribulin, because this is a cytostatic that showed very good efficacy in luminal cancers, very good tolerable, has very good safety profile, very good control of toxicity. So there was a question whether any place for Ribulin after CDK4/6. That's it. And to me, I think even provocational data was received because the data appeared to be better that in the randomized pivotal studies, registration studies that led to the drug registration. So it worked better versus pivotal study. I think this is very fresh data, but I think very interesting data. I think mainly related to the mechanism of hormone resistance development and the absence of particular connections, because I don't know whether there is any resistance to Ribulin. Because there are patients who did not get any chemo at all. So this is luminal subtype, and they were eating just hormonal treatment with any purpose, palliative or adjuvant or neoadjuvant, whatever, but just hormonal treatment. Later, let's say they added mTOR inhibitors, and later they added CDK4/6, and now they progress. And now we understand that we need to administer chemo. So this study tells us that Ribulin is better. But they compared to historical. What did they do? They compared to historical control while patients were switched to chemo, or there was some justification to that. Why? What do we start from? For example, if we administer cytostatic for the first time, what do we start? We will select Doxo. Well, in Russia, the first idea is Doxo, but here is Halovin. Why? Well, molecular mechanisms are studied, and frankly speaking, I don't know why not Doxo, why they selected Ribulin. Well, we can search for justification, probably, if we look at mechanisms of action, but why this option was selected, I don't know. Well, I now have an idea. Maybe initially, as the study is actually retrospective clinical study. So possibly there were patients who did not respond to anthracyclines, taxanes, they reached Ribulin, and then suddenly they saw very long responses, and then they started thinking, why don't we give it a bit earlier? And that's how they added artificially those patients who already started answering Ribulin, responding to Ribulin. So they saw in practice some cases, and they just started doing it. I cannot tell you whether it was initial design or not. Well, I have doubts, because this is quite homemade clinical study, that's just a retrospective selection. Possibly those patients who received anthracyclines did not respond, taxanes did not respond. Then, according to indications, they received Ribulin, and suddenly they saw crazy responses that they never hoped for. And they started artificially selecting additionally these patients to give them Ribulin, possibly this way. Don't you know, Joseph, why was that the design like this? Why Ribulin was selected, not Doxo, and the justification?
It's very difficult to have an answer. I think that you could not overinterpret the results. What is very important is that you have a very strong signal regarding the disease control with a median PFS, which is, as you have mentioned, similar to what you might expect in more aggressive situations. But these patients have been pre-treated with other type of endocrine treatment, with CDK4/6. So for me, the strongest message of this retrospective analysis is that it works. but I could not say that I can use it upfront and not using, for example, anthracycline and taxanes. I'm not comfortable with capecitabine, to be honest, because I'm not sure that they are comparable. But this is the demonstration that this is one of the major chemotherapy in monotherapy that we have as an active one in aggressive disease for me.
Спасибо. Есть еще вопросы?
Thank you very much. Any other questions? Yes, you're welcome. Microphone. In the cohort of patients who continues eribulin, at least retrospectively, any secondary trypanon biopsies, maybe they cardinally changed the type of disease. As far as I know, in the descriptions, it's a poster session. It was just a poster in Miami. And I read the poster. They said they confirmed a luminal cancer. At which moment it was confirmed, not clear. So the question was probably it's the other type of cancer. Maybe it was initially confirmed, or maybe after the progression with hormonal treatment. But there was a confirmation of the luminal HER2 negative. So he's asking probably the disease changed. And the question is, do you frequently perform biopsy if the patient doesn't respond to 3 types of treatment? And the question is to switch to chemo. Will you perform? If there is a lesion, we prefer to do. Okay, good. Good for you. Thank you very much. Thank you very much. So we do continue, and we're coming to the practical part of our roundtable. And we will give the floor to our practitioners, colleagues who are working in the practical oncology. And the first presentation of the case will be made by Svetlana Kuzmichova. Svetlana, the floor is yours. You're welcome. Could you switch off the mic on the table? Switch off. Thank you. So Svetlana will make us intrigued. Good afternoon, dear colleagues. Thank you. Otherwise, I cannot hear. I appreciate this opportunity to share my clinical case. And I would like to say that, well, there was a theoretical part now, and now the confirmation of the words in practice. So, patient, born 1960. He had a diagnosis in 2001. At that moment, she was 41. Very young patient, without comorbidities, ECOG 0, everything is fine, quite active. Well, her position in life, she's in top manager of the company. And this is a tragedy, stage 2, T2 and 1, M0, right side. 2001, she was treated. Good treated, well treatment at that moment. So there was radical mastectomy with the sternum muscle preservation. Histologically confirmed invasive lobular cancer in 4 out of 7 nodules in axillary, and metastasis of cancer-like structure. Luminal B, high proliferative activity index, Ki67 high. Then the patient received 4 cycles cough from March 2001 and 1 Pacli, and then she refused from adjuvant chemotherapy because of extravasation and necrosis in the injection site. So she received distant radiotherapy to the lymph outflow, and in June 2001 radio castration was performed. And then patient successfully was getting adjuvant hormonal treatment, tamoxifen, 5 years, and everything would be okay if 9 years later, the patient demonstrated progression, metastasis into the lungs. So with pleuritis, she is hospitalized to our clinic, and there is a first line of chemo because she had some resources for doxorubicin, so there were 6 cycles of cough. Then patient switches to hormonal treatment, first line, and received Arimidex, 1 year and 2 months. 14 months. In June 2014, with the first line of hormonal treatment, the patient progresses. So lung metastasis, lymph nodes of mediastinum, and in fact, pleuritis is ongoing. Then here, video thoracoscopic examination was carried out, lymph nodes of mediastinum taken, and secondary staining, and we completely confirmed luminal subtype B, breast cancer. Then patient administered second line of hormonal treatment. Patients included into Paloma 3 protocol, and for 3 years she was receiving 35 cycles of Faslodex with palbociclib. Well, tolerates nicely. The best effect was reached after 5 cycles. It was partial response. And then all that time the patient had disease stabilization. Then there was a progression in March 2017 when there were liver metastases discovered and lymph nodes of mediastinum were growing. Patient had to stop Faslodex and palbociclib and comes to the third line of hormonal treatment, which is aromazine, combination with everolimus. Everolimus, she couldn't take it because of toxicity, GI diarrhea. And 6 months later, with just aromazine, she's progressing. At the end, patient is considered to be a visceral crisis and no other choice. And she administered second line of chemotherapy, 6 cycles of paclitaxel with carboplatinum. The best effect, again, partial response. Then, due to the toxicity, because patient cannot tolerate chemotherapy at all, so we performed the reinduction and we went back to hormonal treatment with Faslodex, because the response to Faslodex was quite good. And we decided just to go back to Faslodex. And the patients demonstrated bone metastasis. We added bisphosphonates. So patient lived for 5 months with this option. And then massive progression. Increased lymph nodes, subclavicle, supraclavicle, liver parenchyma, skeletal bones. Patient administered third line, eribulin, standard dose, with maintenance bisphosphonates. And I want to show you immediately the beauty we received. Hopefully you can see it. Oy, oy, oy. We dropped off from the presentation. Yes, now we have to start from the very beginning. So here we received partial response in the liver, but SUF is maximum, reduced 2.5 times. Supraclavicle, almost not detectable, any pathological metabolism. And in the abdominal and the pleural cavity, lymph nodes in the pancreatic head, also SUF reduced twice, cut twice. So at the moment, patient received already 19 cycles of eribulin without dose reduction, tolerates very nicely, very active, employing. So actually, continuous living. That's it. Thank you very much. Yes, thank you very much. Thank you very much, Svetlana. Any questions? I think this patient in American study would be called upon indications, anthracyclines, taxanes, third line chemotherapy. And in fact, all the options, yes, all the options of hormonal treatment, and not the last line. She received CDK4, 6 not in the last line. She was lucky. Well, in fact, when the patients can get, because we are now counting chemo, hormonal, because, well, you know, if you count any drug treatment, it's already seventh line, and in fact, we received some effect. I think this is very good on the one hand. But on the other hand, this data that after CDK4/6, that Halaven is working and working very nicely, yeah, I think we need to gain our own data and to confirm this finding, because in fact, to my shame, when I read that study, I was quite doubtful. I thought, wow, what is that? To me, it was like very disputable. I didn't feel comfortable. Why didn't have comparison group, But now I'm looking at your case, and in fact, after CDK4/6, yes, they immediately administered after start of CDK4/6 with very good effect. Colleagues, do you have any questions here? Comments, remarks? You're welcome. Do we administer something after CDK4/6? Well, until progression. Well, we have a very big experience now with CDK4/6. We have very many patients who are receiving palbociclib, ribociclib, yes. Belmaciclib probably in the future, but we don't have this very active progressions, aggressive progressions. They're still on treatment, and possibly we will use this data in our practice later on. Thank you very much. And now we would like to ask Professor Joseph, what about your practice? Do you have eribulin after CDK4/6 in your practice?
So different lines of chemotherapy. The only fact that is a little bit more difficult, not with eribulin, but in general, our impression is that we have a little bit more hematological toxicity after CDK4/6 inhibitors. That's the only point, because usually if they respond very long time to CDK4/6, even if, let's say, the hematological events are pretty rare regarding the grade 3 or 4, then when you reintroduce an active chemotherapy regimen, sometimes you have to desescalate a little bit the doses of the chemotherapy. That's the only thing. But usually it's what we are doing also.
Хорошо. Спасибо.
Very good. Thank you very much. Well, yes, we move on. Well, we have so many clinical cases, and we're happy to give the floor to Leonid Semenov, who will speak up about his own clinical experience. Could you switch off the mics on the table, please? Thank you. Thank you very much for the opportunity to speak up. This is patient born 1952. Initially diagnosed of right side breast cancer, T2 and 2M0, stage 3. Estrogen positive, progesterone positive, HER2 negative. Started treatment from radical mastectomy in 2013. Then 4 cycles of TAC, then FTC, and radiation. Received tamoxifen as an adjuvant until May 2014, and bleed developed. Patient stopped. Didn't come to the doctors, and no replacement. From May 2017, progression, intracutaneous metastasis in the scarring area. She received 3 cycles of capecitabine. She received 3 cycles. Unfortunately, no effect. Visceral metastasis not reported. No visceral crisis. So decided to provide Faslodex. So patient responded nicely to the treatment, and she was receiving this drug for longer than 1 year, 14 injections. Unfortunately, she progressed with visceral metastasis. So since June last year, eribulin was started. The first injection, well, not very nice tolerability, but later on, with dose reduction, patient continues receiving the drug up to now. So because it's working. So until recently, we were receiving very good CT results, and there is continuation of the positive dynamics. So we yet don't reach stabilization. So tolerability is nice, except peripheral polyneuropathy, but not higher than grade 1. Well, there is interesting thing here. Yes. According to all visceral metastasis, there is clear positive dynamics, and intracutaneous, at a certain moment, grew up a little bit. We decided, due to the fact that there is actually more positive than negative, we decided to keep it. And we referred for local treatment to radiotherapists. That's what she received. So fast electrons irradiation to the intracutaneous metastasis of the abdominal wall in the scarring area. But during the radiation, the patient had episode of fall. And for the first time, we saw brain metastasis, not single ones, and pretty large ones. Although there was opportunity to irradiate with gamma knife. Again, in Granov Center, she was irradiated. So we continued treatment. Brain metastases were for the first time found since the beginning of treatment. So we decided to keep on. Thank you. Thank you very much. Thank you very much. About hematoencephalic barrier penetration, this metastasis, well, if the patient does not fall, you wouldn't probably find this brain metastasis, right? Possibly not. So clinically, she was asymptomatic, absolutely asymptomatic. No headaches, no, nothing. When they happened, we don't know. It can be after capecitabine, and since then, because, brain was not examined, and then she received Faslodex. And yes, they may not grow or may grow. We don't know. Firstly found. Joseph, would you change? Would you change if you see newly diagnosed brain metastasis? Would you change? In objective response to eribulin of other lesions. But doctors didn't examine. She didn't get. They didn't perform brain study. Just accidental finding, and they found metastasis. Do you think we have to switch from eribulin?
So actually, we don't have clear answer about that. In my practice, I will not change if the disease is controlled on the oversides, clearly. What is interesting in your observation is that you have, at two moments, I will say, a position that I agree with, but it's not the classical one we have learned. The first one is that you mentioned that you have more positive than negative results, and then you decide to continue, which is actually what happens in everyday practice in some of our centers. But in fact, this is not validated. That doesn't mean that it's wrong. I will totally agree with what you have done. But the point is that if you go in a clinical trial, and sometimes this is the problem of the clinical trials, if you have a small progression, you will consider the patient to go out of the trial, and sometimes you can even kill a drug that is actually under development regarding that. So this was the first. The second one is that you have applied what are the guidelines according to the HER2-positive disease, which is in fact when you have a progression, solitary or not, metastasis in the brain, you can continue the systemic treatment and do a local therapy. There are some data showing that eribulin might go through, let's say, the blood-brain barrier. There are some data that are controversial, but in any case, nobody knows exactly how it happens, not for eribulin, but even for the monoclonal antibody, for all these kind of drugs. The point is that I agree that if you don't have a progression outside of the brain, I will continue the same treatment and apply a local treatment.
Thank you.
The only question is, what happens if you have patient in an adjuvant setting and then the first site of relapse is brain without visceral mets or bone mets or nothing else? Then nobody knows. If you have just to treat the metastasis with a local treatment, or if you have to then apply a new systemic treatment in this situation.
Мне кажется, это философский вопрос.
Yes, yet it's a philosophical question. So we can think, yes, there were some lesions in the brain, but when they appeared, let's say, as neuro-oncologists say that, bells ring, bells ring. When I heard for the first time in the international conference this wording, bells ring, I thought, why the hell they're talking about it? Well, it's a jargon from neuro-oncologists. They say bells ring, bells ring. We suspect that lesions were there long before the manifestation. The patient is very well controlled systemically. There were no clinical symptoms of the brain. No, not at all, not at all, not at all. Yes, the bells were not ringing. Yes, the bells were not ringing. So that's a philosophical question, when they happened. So what to do in this situation? I don't know. I think if patient with adjuvant gives you the only manifestation is the brain, I would keep the same adjuvant and I would add on radio or cyberknife. Yeah. Do you agree?
I agree, but this is clearly actually the type of experience that we need to share between the different centers. And sometimes what happens is that you learn more from patients than you learn from doctors. And sometimes the patient will ask you and say, okay, why we have to change the treatment if all the disease is controlled? This was history also for HER2 positive. In fact, usually the doctors, we always think that it's easy to change because we are not suffering, we are not taking the pills, we are not using the drug. It's always easier to say to the other one, please do it. But we learn a lot from patients, and usually they are more and more challenging the doctors with this kind of attitude. Why changing if you don't have clear signal that I'm resistant to this treatment?
Окей, спасибо большое. У меня вопрос.
Thank you very much. I have another question to you, Professor Joseph. Do you frequently perform brain biopsies of the lesions, brain lesion biopsy, for the verification of the biological subtype?
Not so currently. I will say that first, we don't do systematically imaging without symptoms. This is our statement, actually. The second thing is that if we have multiple brain, we will not perform usually. If we have a solitary metastasis in a context of, let's say, suspicion at the imaging that it might be also primary brain, sometimes it happens, or that you have a meningioma, it happens sometimes, then we will go to biopsy. And if, of course, it's a solitary metastasis, we can discuss sometimes to have neurosurgery versus or in combination with radiation therapy, and then we will do.
Спасибо большое.
Thank you very much. Any other questions, comments, remarks? Well, we have a hand here. Yes, active hand. Philosophical question. If we speak about heterogeneity of the tumor, very difficult to hear. Deaf like a snail. Thank you very much. If we speak about heterogeneity of the tumor, and if we look at those biological types where the hormonal sensitive receptors expression is 10 or lower, so that means lower expression rate, let's take them as initially resistant, and if we start with chemo in this group, less than 10% of receptors, don't you think that then bigger pool of chemosensitive cells would be eradicated, and the pool of hormonal sensitive cells would be bigger, and suddenly the tumor can be hormonal sensitive, could become. Maybe this is not hormonal resistance, but let's say lower percentage of the cell from the tumor is presented by the sensitive ones. Let's say, yeah, if we chop out first chemosensitive, then probably hormonal sensitive will grow up, and we will kill them with hormonal treatment. What do you think? So that's her idea. Wow, you have so big brains here. Yes, brilliant future for this lady, I'm pretty sure, yes. In fact, the problem of heterogeneity is very actively discussed at different levels, and you are absolutely right saying that using particular type of treatment, targeted treatment, we destroy the evil clone which responds to this treatment. And if we speak about the lower level of expression, so we administer cytostatic, so possibly clone with a lower level of expression, more sensitive to cytostatic, but it does not mean that will not respond to hormonal treatment. I think in this situation we should use both endocrine and cytostatics, not to do what you just said before, grow up of, love to cytostatics, will chop out cytostatic sensitive, and there is a bigger niche, free space for the growth of hormonal sensitive, true hormonal sensitive, I mean. Studies with lower level, well, just started enrolling. This is last position, very cautious position that, well, possibly let's include these patients in the scenario of triple negative, and later on make some subgroup analysis for them, looking at how they respond to these or those options of treatment typical for hormonal negative. tumors. So it does not mean that tomorrow all of you will be treating them like triple negative. No, no, no. But there is some sensible idea here. I would not reject here from endocrine treatment in this patient. So possibly chemo would be more effective for them upfront than hormonal treatment. But hormonal treatment, it does not mean that they don't respond at all. So possibly it should be like maintenance maybe after chemo. Yeah. Well, it's difficult to manage them with hormonal because hormonal cells are not multiple. Probably cytostatics would give better response, yes. Frankly speaking, in practice, well, I expected this question, how many in points, because we're not measuring in percents. So Ballard, so we were counting with morphologists, we thought that probably this is 3 to 4 by Ballard, because 2 points, this is true hormonal negative, because points are measured by the number of positive cells that added 1 to 3, then the level of intensity of staining. In order to get 2, you should have one is here and the other one in there. So 1 is the minimum, that means 1 cell, which is weakly stained. So this is called 2. This is true triple negative, hormonal negative, but 3-4 actually can go in this group, less than 10%. In the real practice, this is my position, that any of you, when you see disseminated cancer in the patient with 3 points of estrogen and progesterone, you would hardly go to hormone treatment. Or maybe you would administer, Joseph, what do you think? If 3 points of estrogen receptors, would you administer in the clinic?
You have always to be careful about several things. We all speak about heterogeneity like we have discovered something new. But when you look at the history of breast cancer, since 30 years, when you look at the reports, it's written 70% of the cells are positive. That means that 30% of the cells are not. So when you look, you have a small group of patients that are really clear, all the markers that we use are negative, or all the markers that we use are positive. The vast majority of them, even in the primary tumor, are heterogeneous tumor. And regardless of that, you treat the patient. Why? Because if the surgeon do not cure, sometimes it happens, you need to do the job if you can do it. And if you don't do it, the patient might, I would say, die early or late. If you do not die early, he will die late. What does it mean? It means that nobody knows what is the evolution of the disease. That is the crucial point. And initially, what makes the situation wrong for us is that we are fighting between 2 options, endocrine and chemotherapy. Actually, when you discuss with a lot of oncologists that are involved in breast cancer, we are the majority thinking that in some situation you might combine both. And I have some patient when you have shown the PET FDG, for example, okay? If you have an answer in several sites, the colleagues have said before, your colleagues have continued with the endocrine treatment, no, sorry, with the Ribelline, and I've just provided radiation therapy in one of the sites that do not respond. Sometimes what we're doing is that we are just doing the biopsy and we had, for example, endocrine treatment in combination with the chemotherapy because this clone is estrogen receptor positive. So there are several approaches. It's difficult. What is mostly difficult is to imagine that we will have a tool that will help to have the description of all the different sites. So I agree with you. I will treat, to answer your question, this patient, why not with endocrine treatment, even if the level is not very, very high, if the situation is not aggressive, if I have time to see. Because at the end of the day, I'm just the doctor. And the patient is taking again the pills. And the patient is taking the chemotherapy. If I can offer to the lady the same duration of life, or even better, with biggest quality of life, less toxicity, I will offer this option. When you are very young, you always think, I will kill the disease. At the end of the day, we will all die. That's the point. But the other point is that even if you die, you might do a lot of things during your life, even with a metastatic disease. So you will be more aware about the quality of the life. And it's why even in small proportion of patients that are not very endocrine sensitive, or they don't look to be endocrine sensitive, you might test if you don't have aggressive disease. And at the opposite, even if the patient seems very endocrine sensitive, if the disease is very aggressive, I will not take the risk not to give the drug that will control the disease as soon as possible.
Спасибо.
Спасибо. Нет вопросов?
Thank you very much. Any other questions? No questions. We move on. Yes, we have one more case, and this is Natalia Raevskaya. The floor is yours. Can you switch on microphone on the table, please? Thank you. Good evening, everybody. Can I have a short remark about the previous question? So now more and more frequently, we perform biopsies during progression, and in a number of cases, we really see when there are estrogen or progesterone receptors where initially we didn't have any, so they change, or they increased in the percentage. Yes, it happens. It happens. It's true. So my presentation is our case, our own case, devoted to Ribulin treatment. It's the wrong button. I'm so sorry. Where do I have to press? Thank you. Thank you very much. So this is our patient, born 1953. Initially diagnosed in 2012. Here you see her diagnosis, initial diagnosis, which is T2N1M0. We started. Then this is her comorbidity. Well, nothing special. Diabetes type 2, autoimmune thyroiditis, chronic gastritis, remission, so CHD, hypertension, myoma of the uterus. Well, standard stuff for 50 plus. Well, first she was diagnosed in 2012. This is left breast, T2N1M0, stage 2B, and the first was done is mastectomy. Histological picture is here. Metastasis in 3 out of 12 lymph nodes, immunohistochemical staining, estrogen, progesterone 0, HER2 no 0, Ki67 was not detected, and 6 adjuvant cycles by AC. Now we would treat her differently, but in 2012 we treated her this way. Then progression happened 1 year, 9 months later, not surprisingly. X-ray of chest, lesion in the right lung. So in CT, so this big lesion was confirmed and multiple minor. BRCA not found. Oy, oy, oy. It just disappeared. And the first line, treated line, paclitaxel, 8 cycles, mono, stabilization, and even reduction of a lesion, big marker lesion in the right upper lobe of the lung. Paclitaxel gave her peripheral neuropathy, stopped, dynamic follow-up, but just 3 months. 3 months later, progression happened, and the patient was switched to the next line, carboplatinum. At that time, we used this scheme, sulcophosphamine with carboplatinum. Right now, it's not in the standards, but in those years, we used it. Progression, very fast. September 2015, increased number of lesions and the size of the lesions. Here they are. This is September 2015, and at that moment we had already Ribulin available, and the third line of chemotherapy was actually a Ribulin in the standard regimen, absolutely standard. The beginning of treatment was October 2015. Then after the second cycle, without visual effect, after 8th cycle, and I would like to draw your attention to that, how late was the first response. 8 cycles and first response. So I want to tell you, don't stop, continue. Don't stop, continue. So the first positive dynamics, September 2015. Oh, it's a bit opposite, sorry. So this is lymph node before and after. Line 3, continuation until 19th cycle, 19, and we received CR. In CT of May 2017, you can appreciate the effects are slow, not fast, but in May 2017, she yet has positive dynamics. So in fact, we don't detect any tumor at all. So the patient was treated until March 2018. She received 31 cycle of Ribulin and no data for progression. And the question was what to do next, because we even came to the conference because we didn't know. We came to the conference with this case. We didn't know, but actually life corrected everything. Well, adverse events, very well known. I think we can skip it. When the patient came for the next Ribulin injection, we found arrhythmia. We don't relate it to the drug, so it can happen without Ribulin at all. So she referred to cardiology treatment. Then she got cold, there was influenza epidemic, then bronchitis, then, well, that means there was the following. She skipped too many injections, as in fact, she was almost in remission. We thought, well, as soon as so many injections were skipped, we can stop at that and we can follow her. She's followed up until now. Instead of big lesion in the lung, there is fibrotic spot. Other metastatic lesions not detected. Currently, she's planning her next examination. 35 months in response. Well, again, wrong button, but with that I actually can finish my case. Well, what would you change, I think? Well, but with this effect, well, hardly to say what to change, nothing to change. Difficult to offer anything else, but yeah. So we have many patients who we are treating with Ribulin. We love Ribulin, in fact. We like it very much, and we believe it has a very low toxicity profile, tolerated very nicely by the patients. Patients like it. Well, we never ever had such brilliant results, but we have some other patients who are in stable situation with Ribulin treatment, and by the end of the year we are planning next examination, and then possibly we will report the results. Maybe not so brilliant results, but nevertheless also very good results as well. Thank you very much. Well, the organism of the patient decided to take therapeutical drug holiday. Did anybody see such effects in the Ribulin? Complete regression. Well, we'll make an intrigue. We will have cumulative Russian experience. We will show you. In fact, I want to open a secret. In fact, St. Petersburg is very famous by your love to Ribulin. Yes, yes. In our cumulative Russian analysis, we had many patients from St. Petersburg specifically. So please don't tell us that you don't have many positive results. Well, you have even longer responses, believe me, longer responses in the treatment that not many people believed in. And they ask, what, really? Is that possible? Oh my God, oh my God. Well, in fact, St. Petersburg is really big site of Ribulin administration. Yes, yes. We know that you love drug, you administer drug. We see it in our Russian experience, cumulative Russian experience, yes. Well, maybe biologically St. Pete women are different. Oh, yes, Vikings. Well, good doctors, good approaches. Good doctors, good approaches. I think, you know, a correct patient, correct treatment, and correct time. That's my saying. Well, thank you very much. Any questions? Any questions? Thank you. Thank you very much. And now we are having a very interesting part, French experience of using Ribulin in routine practice. Well, you never ever heard it before. Wow, very unique, very interesting, very interesting. So, at least to us.
So, again, pleasure to be here. I will present to you. It works? Do you hear me? Yes? Yes. I will present to you the results from an observational study that was provided in France. A friend of mine, William Jacot, was the guy that promotes this approach to the ESME database. ESME database is actually a database involving 18 oncology centers in France. When the collection of the different data are regarding the patient journey along the disease, the metastatic and the adjuvant one. Actually, we have one paper showing that in the adjuvant setting, sometimes endocrine treatment is really more difficult to deliver than chemotherapy, which would be probably very provocative in the next presentation at the ASCO or, I don't know, ESMO meeting. But in any case, this database is very useful for us. And at one moment, we have a lot of discussion regarding the place of chemotherapy and the place of the different agents of chemotherapy regimens in the strategy, and do we have in real life the same result that are actually provided by the clinical trials. And the point was that in clinical trials you have a biased selection, as you know, of patients in very good condition. So the ESME program was focusing on metastatic disease, and we have addressed the question among these different centers of what is the outcome of the patient regarding the overall survival that have been treated with eribulin during a period of time between 2008 and 2014. And we know that during this period of time, about 100 patients have been treated in these 18 centers. And treatment might be delivered at that moment, I think about eribulin, in second, third, or fourth or further line of chemotherapy. The primary endpoint of this analysis, even if it was a retrospective one, from a methodological point of view, we have just wanted to focus on a good methodology. The primary endpoint was overall survival, and the secondary endpoint of the trial, of the retrospective analysis, sorry, was PFS according to the different lines of treatment where the patient were treated with eribulin. So this is just to show you the database. I'm sorry, this slide is not in Russian, but there is no problem, I think. But what I want to focus on the slide is when you begin with the majority of the patients that are here, 100, you will see that the patients that have received second, third, or fourth line of chemotherapy are less than half of the initial number of patients. This is due potentially to they have received over-treatment, like endocrine treatment. This is one of the possibilities, but sometimes also the possibility is that if they do not receive an active treatment in first line, they will not have possibility to be treated in second, third, or fourth line. The second point is when you compare eribulin, second line, third line, fourth line, the number of patients to the other chemotherapy regimen that have been delivered in this situation to the patient, you see that the proportion is always smallest and significantly smallest. It means that if you want to demonstrate a superiority of one arm to another one, theoretically, you will have more difficulty because you have more patient in the control, what I will say, arm, that you will have in the eribulin arm. This is not a randomized trial, but just again to show you that and to emphasize the fact that you are comparing events in 300 patients comparing to 5,000, 600 to close to 3,000, and 500 to 1,000. In fact, this will give more chance to demonstrate that on the other arm, it could be better in general. However, when you look at the proportion of the patients in second line, third line, and fourth line, and if you look at the different treatment that the patient have received according to the biology of the tumor, the type of metastasis that they have, and also the number of metastases, there is one imbalance every time. The imbalance is that if the patient are HER2 positive, the patient that have been treated with other chemotherapy regimen in metastatic setting have received 3 to 4 times more anti-HER2 treatment in combination with chemotherapy than eribulin. Why? because here we have put all the different patients that are HER2 positive, HER2 negative, hormone receptor positive, negative, etc. And we are focusing on the patient that receive chemotherapy. Among the set of metastatic patients, a big proportion are actually potentially HER2 positive, more than that we have in the adjuvant setting, and they all received in second, third, and fourth line, or the majority of them, anti-HER2 treatment. So the point is that it will not be fair, knowing the importance of the anti-HER2 treatment, to compare eribulin monotherapy in HER2 positive disease to chemotherapy plus anti-HER2 in HER2 positive disease. It's why the analysis was focused on HER2 negative patient according to the HER2 status to know exactly where we are going. And this is actually, when you look at the second line, third line, and fourth line, as I mentioned to you, the differences between the two groups, eribulin over chemotherapy, regarding the exposure to anti-HER2 treatment. And you see that there is a huge difference, making this imbalance and explaining why the analysis was performed in HER2 negative population, just to stress that we are dealing with an overpopulation. However, the primary endpoint of the retrospective analysis is here. And again, what is interesting, and how it was mentioned that our colleague from Miami have shown, from US at the Miami meeting have shown, is that even here, when you look at the median overall survival comparing eribulin to other type of chemotherapy, we have close to 5 months of difference, which is pretty respectable and clearly even a little slightly better that we have in the randomized trial. So in real life, when the patient are candidate to receive eribulin, the signal that we have in our database in France is that not only it works, but it works better regarding the overall survival comparing to the other type of chemotherapy regimen that we have. The second thing is that if you look at the different lines of therapy that the patient have received after second one, this is the PFS, first. The PFS showed that you move a little bit from 4, little bit less than 4 to 4.5. It's statistically significant, but it's not clinically relevant, I have to be honest. But the point is that, as you mentioned with the previous case, something special happens sometimes with eribulin. One of the hypotheses is that it targets not only tubulin, but it may also, by this way, influence the mesenchymal transition, the epithelial-mesenchymal transition, and that with this way, it can explain that the metastatic evolution is clearly, slowly comparing to other type of chemotherapy regimen. And the other point is that, back to your case, when you are BRCA mutated, we have also the same experience that it might work pretty good. So we are actually dealing with one trial trying to address this question in this situation. If you look now what happens in regarding the overall survival, regarding overall survival and PFS, comparing to the clinical trials we have, these are the results from the EMBRACE study and the 301 study. You see that we have about 3 months difference when you look at the overall survival. We have about 1.5 months regarding the PFS. But again, in this situation, the most relevant results are always the overall survival with eribulin comparing to the PFS. And if you take out the HER2 positive population, when we have, again, even in 301, imbalance between the two arms regarding the anti-HER2 treatment, we find, again, the same results with a benefit comparing to capecitabine in second and third line of eribulin regarding the overall survival. So this is very, very consistent with all the data we have until now. So I will say that, our database was pretty important because we have discussed last year with the regulatory agency in France about the drug that might be maintained in the reimbursed basket or not. And I will say that probably the ESMA results have helped a lot the clinician to continue to have the reimbursement of the drug because we have provided in real life data that overall survival is still better with eribulin comparing to other strategy in second, third, and fourth line. Thank you very much.
Thank you.
Спасибо большое.
Thank you very much. Well, in fact, very elegant data. Any questions about that? Joseph, to what line would you prefer eribulin to use in your patients, keeping in mind that in the second line, well, probably insignificant difference, time to progression. In line 3, 4, there is more significant even for overall survival. So very interesting that line 3, 4 and time to progression are significant, you know, and overall survival is significant. But in the second line, well, it shows the efficacy, but progression-free time probably positive, but not overall survival. So what pool of patients do we have to select, and in what line is most preferable? What do you think?
It's always more difficult to show in earliest line a PFS and overall survival improvement comparing to the latest one. The fact is that in my institution, I'm using eribulin usually in second or third line. It depends. Second and third. Pretty early in the situation. Out of the discussion that I have with the patient, sometimes the patient, because I have to aware the patient about the toxicity effect and potentially the hair loss, etc. Even if sometimes you can control it with eribulin, but when I have this approach with the patient, I give arguments pro and con regarding the different drugs. And I have to confess that usually when it's time to discuss the chemotherapy, they all agree that if you as a doctor are convinced that overall survival benefit is important, they will follow the rules. And the rules are using it when anthracycline and taxanes are not actually a drug that you might deliver to the patient, because you consider that the patient is resistant, an early, let's say, relapse after the adjuvant situation, or you have a cumulative toxicity, etc. So it's usually second or third line.
Thank you.
Well, today our topic is hormonal sensitive tumors, but triple negative, let me ask, triple negative in Halloween. In our case, which was reported by Natalia, that was quite, well, good effect, very good effect, complete regression, and that was triple negative, you know, triple negative. But what is your position about triple negative? What can you say? What do you do? Halloween and triple negative.
So I think that the interesting thing with eribulin from a clinical, let's say, perspective is that you still have patients that will answer eribulin even if they have progressed after taxanes, which is not so frequent when you look at, let's say, other type of compound that are pretty close, like vinorelbin, or when you switch from one taxane to another one. So there is no cross-resistance. This was published in preclinical data, but in clinical situation, you have this kind of information. The second point is that your patient was BRCA, I don't remember, BRCA1 or BRCA2 mutated? She was BRCA. She was not mutated? She was
Not mutated.
Okay, because we have also experience in BRCA mutated that it works very well. And I will say that usually in chemosensitive population, like the triple negative, eribulin is probably one of the major drugs that we have to use. The bad thing is that this drug was not developed in early breast cancer. This was the bad thing. I'm sorry to say that, but because they had some opportunity to think about strategies, even in neoadjuvant approach, that were very important. And I will say that actually, if you look what happens in neoadjuvant, if you do not have pathological complete response because we use widely neoadjuvant approach, then we perform adjuvant capecitabine. Okay? Yeah, so then if this patient relapse, our first line is now eribulin. This is to answer your question.
Профессор Жозеф просто не знает.
Professor Joseph simply doesn't know that in St. Petersburg we had a study on neoadjuvant eribulin with platinum. You simply don't know. And comparison group was taxans with platinum. Well, many questions to this study. Yes, not quite correct doses, not optimal doses, blah, blah, blah. But in the neoadjuvant, they did not show advantages versus taxans. So St. Petersburg also studied that, already studied. Well, we are enrolling at the moment triple negative group who did not respond to neoadjuvant, and by guidelines, if they do have residual tumors, we have to administer capi, citabine. But we administer ribulin. And we want to see how, with residual tumor in adjuvant regimen for triple negative cancer, how ribulin will be working. So that's our idea.
Adjuvant setting in St. Petersburg. The point is that PCR is always interesting, I agree, but I don't remember that if you have some data regarding the IDFS or overall survival, actually.
Нет, там в этом исследовании не было данных по выживанию.
No survival data, no survival data.
If you have difference in IDFS or OS, and regardless of the PCR, that might be possible if the EMT hypothesis is one of the valid one, you might have a signal, even if you don't reach a better PCR.
Well, in breast cancer, there are so many non-standard things, so that's exactly when you have some non-standard situation. This is what we are using because we have a school, difficult case in oncology. We're actually discussing the cases that are not typical, or we don't know what to do. Because when we know the guideline, line 1, line 2, line 3, it meets criteria, that's great. But when the situation is, let's say, 10% of cells, 3.34 estrogen progesterone. So how to consider this patient, how to start treatment, what to do? And Ki67 probably not high, maybe 20, but estrogen progesterone, very few, HER2 negative, well, you know, these patients, which cause normally many questions. Well, I have an impression from Ribulin that we use it more frequently when we're already treated by standards. And somehow, this drug somehow works, surprisingly. Probably there is some pool of cells that are sensitive specifically to this mode of action. And it started growing, you know, after CDK4/6, but still effective. How come? How come? Eribulin is effective. Eribulin is effective for residual tumors after neoadjuvant treatment. Somehow it is effective mainly in line 3, 4. Then maybe in the line 1, 2, actually, we don't use it, right? We don't use it, right? Very rarely, very rarely. So this drug, I don't know, maybe this is a drug which overlapping resistance to everything. So there is some magical mechanism. I'm not pharmacologist, I'm not biologist, I cannot tell it. But clinically we see it, we really see it. Thank you very much. So now we're coming to the next presentation. So Irina will tell us about Russian experience with Ribulin. So this is cumulative data of the Russian Federation. Yes, and this is our response to Chamberlain.
Итак, российский опыт. Что-то произошло волшебное, мне голова...
Russian experience. Well, no. I can see the whole audience. Magic happened. Now the screen is down here. I can see you. So who do we administer chemotherapy in luminal breast cancer? We already identified it. So these are patients, actually who is for chemotherapy? Patients with hormone negative status, patients who are resistant to endocrine treatment, or patients with visceral crisis. So no standards of treatment, we have recommended lines. We know that if anthracyclines, taxans were not used before, we have to use them if there is no contraindication to that. And also Ribulin is a drug of choice in patients who were already pre-treated by anthracycline taxane. Well, the disease with luminal breast cancer is this one. So what is left is triple negative? And so many questions without any responses, let's say, because there is no targeted options. Regardless of the attempts, still it's most unfavorable type of disease that we are trying to select a key. So, and among recommended drugs for the treatment of patients, patients who were receiving anthracyclines and taxanes, we see here Ribulin. Why specifically Ribulin? I totally agree with Professor Joseph. So this is a drug with unique mode of action. It has, well, it is the side poison, actually. It attaches to the tubules, then tubulin forms aggregates which are not working, which are not functioning. But this is the REC mechanism, cytostatic, anti-cytostatic effect. But in fact, the biggest surprise of the drug that it has a lot of indirect options of cytostatic effects, including phosphorylating of BCL, which is apoptosis start, and PARP splitting, and this is particular sensitivity in case of patients with mutated breast cancer, and direct mode of action like remodeling of vasculature, because it can restore circulation in the tumor, that those cytostatics that even it didn't work itself, but the other cytostatics that can be administered after would work better due to the fact that there is better delivery to the tumor. So this tail effect, this advantage of overall survival, can be due to this mechanism, opening of vessels, and also in terms of EMT, epithelial mesenchymal transition, EMT. I want to show you what is that. In order to give metastasis, in order to colonize the organism, colonize the organ or other organs, the tumor should obtain a virulence property. It should get out of tumor bed, go through the vascular barrier, again go through the vascular barrier, and to intrude into other organs and tissues and then colonize them. And these are just the cells who are very close to mesenchymal type of cells, because epithelial cells, they don't have this high activity, and the Ribulin actually blocks this transition. He makes this transition of mesenchymal component back into epithelial. That's why with Ribulin treatment we frequently see that can be aggressive tumor characteristics like triple negative, but it's luminal-like behavior. So it becomes very similar to a very favorable subtype of the disease. So we have several evidence-based data from randomized trials, and they show that the drug is not just working, but it's very beneficial in increasing overall survival, and this is statistically significant benefit, which is especially important for the patients with triple-negative cancer, because for this option of the disease, we don't have any targeted options. Having international experience, Russian doctors and Russian oncologists also had an idea to pool cumulatively Russian data and to see how the drug is working in real Russian practice. So this idea came on stage back in 2014, and we decided in the patients who in real practice are receiving Ribulin to assess efficacy and safety of this treatment. So for about 4 years, we were collecting this data in experience 35 oncology centers of all over Russia. So we selected 459 patients, 459. Well, first 3 years, we're selecting single cases, case by case, 1 or 2 cases from different clinics. And we managed to enroll just 168 patients. As soon as these 168 patients were treated during the first 3 years, and we already had quite an effective option, as we understood, so then we started actively administering the drug. And then for the next year, plus 300, oh my God. So it's just pushed up from different regions. So we decided to assess efficacy and safety. So what are the patients' population? Median of age 56. Please appreciate here, these are females from 29 up to 81 years old. 81 years old. Mainly either patients with visceral metastasis, 73%, patients who had more than 2 metastatic lesions, that means polyorganic involvement, 42%, and also visceral metastasis presented here by liver involvement, lung involvement, pleural involvement, chest involvement, and even brain involvement. In routine practice, we also assess this group. The median of previous lines, 2. Majority anthracyclines, taxans pretreated 94%, and single situations just anthracyclines or just taxans, and every third patient received also capecitabine. Initially in our study we had all biological subtypes because really we wanted to accumulate experience. We included all the patients with all biological subtypes. Later on, as it was said before by Professor Gligarov, positive, that's another story, definitely, because a lot depends on the type, efficacy, duration, etc., etc. That's why directly you cannot make the transposition of heredity. That's why we wanted to initiate HER2-negative breast cancer. And like in France, 381 patients included in the analysis. So like in France, we received it in line 2, line 3, but there were patients in line 4, but line 5, 6, 7, and 9, you see even 9, they received this treatment. What were the results? The level objective response rate, 20.5, including 3% of CR, 17 partial. Growth control was reached in 73% of patients. Long stabilization, longer than 6 months, plus 20% more. Median of progression-free survival in general group of HER2-negative cancer, 4.8 months. And then we just heard today the first results, let's say 10 months after CDK4/6 inhibitors. But these are very early results. But this is a fact. And if this is just first, second, or the third line, there was a minimum number of patients who received in the first line because of metastatic cancer. But for example, they received anthracyclines and taxans before in adjuvant and non-adjuvant options, and they could not use them anymore at the stage of metastatic cancer. Not many patients, but there were some. So in these patients, the clinical efficacy rate was the highest, 82%, and complete and partial, almost 25%. If they were later lines, line 3 or 3, 4, 5, 6 up to 9, then definitely clinical efficacy rate was 59%, and there were fewer complete and partial. It's interesting to mention that, and by the way, although it seems that clinically, in the clinical sites, it's a minimal benefit, so in earlier 1 month, but it appeared to be statistically significant after the analysis, and it allows to recommend earlier lines for this molecule. So patients with luminal and triple-negative cancers, they have very similar results. 3% of complete responses in both groups, 52 and 53% partial responses. Stabilization and partial response was higher rate, 20.5 versus 12 months in luminal cancers. It appeared to be that PFS, statistically significant, was not different in triple-negative and luminal. That means drug demonstrated very nicely in triple-negative. Because we have many elderly, we decided to analyze subgroup elderly, 60+. 1/4 in the study, every fourth one, 60+. We're always afraid to administer cytostatics here at 60+, because we're elderly group with all comorbidities, especially pretreatment toxicity, etc. So in this group, efficacy of treatment was not worse. So median of survival, progression-free survival, and objective response rate was comparable in the group of less elderly. What was the tolerability in Russian cohort? Well, good tolerability. Neutropenia, grade 4-5, just 13%. Thrombocytopenia, grade 3-4, just 8%. Unlike previous studies, especially randomized. So somehow, in Russian females, neuropathy was very rare. Difficult to say why. Maybe because the doctors did not collect the medical history about neuropathy and they didn't ask about the symptoms, or maybe the patients were silent and they didn't want to say that something disturbs them, because if this is effective treatment, they were afraid that the doctor can cancel if something wrong is happening. But in fact, in our analysis, when we counted the results, peripheral neuropathy was represented just in 3% of the cases, grade 3-4. And as a result, dose reduction was required just to 14% of the patients, and the rest test, was receiving treatment in the standard regimen, full dose. And then, in the analysis, we found something interesting. By the way, this data has never ever been presented before. In no experience, no study, we found out that in every fifth patient, there is super sensitivity to eribulin. 87 patients who had progression-free survival, 8 months plus. And this group also included all biological subtypes. They were similarly distributed. Moreover, there were also patients who received not simply in the first, second, third line, but also line 6, line 7. So treat, no response, then line 5, 6, eribulin, and suddenly pop up. You know, like a devil from the box. Yeah, like a devil from the box. Yeah, it works. Shoots up. There's a better response. 10% complete responses. That means every 10th patient, then one metastatic cancer, complete regression of all metastatic lesions. Wow. This is not the first, not the second, sometimes line 6 and 7. Well, sometimes it's like a miracle, you know, it's like a miracle. Like Papa Cap. And 67% had long-standing stabilization, 24% partial response. And to confirm that, I want to show you several cases. Patient, age 60, triple negative, 3C. Primary treatment in 2014. Well, standard treatment at that time, anthracyclines, neoadjuvant, then radical mastectomy, then taxanes post-op and radiotherapy. And, you know, this hamburger or sandwich was very popular. Well, something was done before surgery, something was done post-surgery. Then 1 year later, regional relapse, you know, with shield-like involvement of the sternum. So binaural taxane, docetaxel, platinum, so everything's negative dynamic. And like salvage treatment, the doctors thought, why don't I administer eribulin? Since March 2016, they administered treatment of eribulin, so the patient received 10 cycles, and you can see no response to 3 lines, and then the patient had very good response, you know, especially cutaneous manifestation, this tumor-like infiltrate, which not simply local regional, but also came to contralateral breast, to the abdominal wall. And, you know, very good response to eribulin, although it was used not in the first, but in the second, but in fourth line. Other clinical example, patient age 61, locally advanced breast cancer, also triple negative subtype. Primary treatment in 2013-2014, pre-op chemotherapy, mastectomy, adjuvant chemo. 1 year metastasis in the liver, biopsy of the lesions confirmed that this is progression of the triple negative. First line taxanes plus platinum, and for about 1 year the patient was receiving it. At first, very good partial response, stabilization, and very fast progression. And she came with this clinical picture. Well, radiologists tried to count 100 metastases in the liver. 100. Probably very recently, this case would be considered incurable because, you know, to treat the patient with such massive liver involvement would be even dangerous due to the fact that even if she responds very fast, it could be tumor lysis syndrome or whatever, so or liver failure, whatever. But actually, doctors were not afraid. Probably they had nothing to lose, and they decided to try. And they administered eribulin. Slowly but steadily, effect was growing. After 2, 4, 6 slides, well, I think in 1 year of treatment, the effect was reached as a complete regression of all the lesions in the liver, and the patient continued treatment. And at a certain moment, we even lost her for follow-up, I think after cycle 3 for eribulin, because she went to Germany. So we tried to contact the patient to find out her outcome. So we didn't know the outcome, and recently she came back, and she told us that, doctors, in fact, I continue eribulin. It's already cycle 60. Can you imagine? The treatment was continued in Germany, and she feels very nicely, feels good, no dose reduction at all. She's a very socially active lady. And from adverse events, just neutropenia, grade 2, and neuropathy, grade 1. Yes, these are cases, 100 mets in liver. So we can conclude that in the Russian population, the drug also demonstrates very good results, like in the global level, at the global level. Efficacy definitely depends on the line. Preferably, we should administer earlier. But even if the patient does not respond, please remember that possibly these unique mechanisms of indirect cytostatic effect will help this patient later on have more successful cytostatic treatment in the further lines. So all our attempts, and definitely we would be happy to find out those sensitivity markers that allow us to separate that sensitive cohort where we can shoot the apple, administering eribulin, understanding that this patient can have super response, because 20% from our patients had magnificent response to eribulin treatment, and we would like to understand why actually. But right now we don't know the answer, because in this group appear to be patients with different biological subtypes, with different lines of treatment, two mix, big salad. And maybe in the future, when these studies are carried out, we would be selectively approaching to the treatment and administer the drug, let's say, targeted way for specific cohort of patients. Thank you very much for your attention. Thank you very much. Any questions? Because you have your patients there. Yes, yes. And actually, there were many patients from St. Pete, many of your patients here. Thank you very much. Thank you very much for a very interesting presentation. Predictors. I heard that patients I cannot hear. Better effect of something. Is it true or not true? Maybe we get from the answer. Well, difficult to say. I never saw such data. I think possibly, if there is such data, well, you know how it can be explained. Particular lysis activity of cells, liver cells. Maybe this is even tumor lysis syndrome, particular necrosis of tumor cells in the liver, possibly. And this is how we can explain the efficacy. Well, I, frankly saying, didn't see such data. Different analysis was done and different explanations tried to do, but I want to say that in our group of patients that had this super effect, almost all gave very slow response, slow responders. So very rarely, if somebody would have great response after 2 full cycles and sustainable, it's like lake engine, 2 cycle stabilization, 4 cycle stabilization, 6 stabilization, then 8 partial regression, 10 cycles. Oh yeah, it's getting better, this partial response. Slow engine start, and I believe that such these are non-mitotic mechanisms, I think, when they're slow responders. When we need time to relaunch this reversion, to remodel vasculature, maybe to help apoptosis to a certain extent, and to destroy the tumor itself. So yes, as far as I understand, well, audience here is very well educated. You never do it. Even a local progression, you add on local treatments. You don't stop treatment, but not all the regions of Russia can be proud of that. And very frequently, somehow, especially young doctors, where they don't see the response after, 2 full cycles in a partial response, they believe no efficacy and they stop the treatment. So somehow stabilization in many doctors associated with absence of response. No, stabilization is a very good response. If patient can live with her 2 centimeter metastasis, especially in the 7th line, in line 7, it's luxury, So she has this piece in the liver, she works with that, so what? It's not growing, everybody is happy. In your case, as we see, you understand the efficacy of treatment, you assess it perfectly, and you even add on some local methods. This is really great, but you keep her on effective treatment, and this is good choice. And Natalia told us very nicely, don't be in a hurry to stop. Wait a bit. It can come one day, especially patients with sort of late engine start, when there is accumulation of the response. So normally they can shoot up very nicely in a very long-standing and super effective examples when we see very sustainable partial response, sometimes complete responses. We even had a patients where we took a biopsy of that frightening zone of solitary stuff to see whether there is any tumor, and they proved that this is just fibrosis, complete response, histological response. So we confirmed really morphologically complete regression of the metastatic lesion. Yes, there were such cases. Irina, thank you very much. Can you tell me, it appears to be that if we wait this late engine start and these patients, let's say, so quite long life expectancy with these patients, because ECOG poor, eribulin is not indicated. So it should be patients with pretty good ECOG to wait for this, to wait for this ignition. Because if we think now that we administer and we have to wait, the patient should leave, but the patient leaves because we treat, or we treat because he leaves. Well, in our study, in the Russian experience, there were patients not simply with ECOG 0-1, but even ECOG 2. In those patients where ECOG 2, that it is due to the disease and the rolling out of the response first shifted ECOG 2 into ECOG 1 and then ECOG 1, even ECOG 0. But when we administer something, we should always, have analysis, risk and benefit, whether the patient tolerates or not. And if we understand if this is a difficult clinical situation, probably nobody will judge you if you are afraid to administer such active cytostatic treatment. But why eribulin is good? Because actually it itself does not worsen the quality of life, so there is not much burden added. It either helps and then switch your ECOG 2 to ECOG 0 probably, or at least it's an attempt which is depleted and you will know for sure that we used it and it didn't work. That's it. Actually, not much harm, so quality of life is very good with eribulin because it's tolerated very nicely. And to expect that it will increase worsen even bad quality of life. We don't expect that, not at all. So we treat patients because they live nicely, because they live long, because those who unfortunately resistant to our treatment in the line 1, 2, 3, they die very fast normally. But those patients who respond nicely, so it's a new chance, there are new wings and we can fly. Any other questions? Joseph? Mike?
Вот на самом деле хочу поделиться в этом году.
Yes, I would like to share. This year presentation was presented at ESMO. I was speaking up. Well, big surprise, because those speakers and prominent speakers, famous people like Professor Joseph Gligarov, global experts who visited Russia before, they know that the situation in Russia is not so bad, that we actually treat according to the guidelines, not simply Russian guidelines, but our guidelines mainly copy-paste of international guidelines. Something from NCCN directly, something from European guidelines. But the vast majority of doctors in Europe, they somehow believe that in Russia the situation is really bad. Bears are walking in the streets and people are playing balalaikas. Well, surprise was great in the audience. Well, first, that we know this option, that we use this option, that we have such good results. And moreover, let's say at the end of the event, it appeared to be that as Europeans said, why the hell we didn't think to count our cumulative European experience? Because we have many more patients, and the drug came earlier in our practice, it was more available, blah, blah, blah. But you know what? Yeah. We showed off. Thank you very much. So shall we wrap up? Well, in fact, many thanks to everybody. I think we enjoyed these 2 hours very much. 2.5, 3 hours, yeah, maybe 4 hours, I don't know how much time. So fast, time is ticking so fast. I think it was interesting and useful and fruitful. We would like to thank Professor Gligarov for the opportunity to come, to find time in his busy schedule, to come from France, to meet Russian doctors, to tell about his experience, to share his knowledge. his skills, his experience, expertise, practical tips and tricks. Many thanks to those of you who came today, also found time after your working hours or skipped some of your working hours. And in fact, we finished almost on time, and this is really very good. This is good quality event. Thank you very much, and have a nice day.
Oh, thank you. Thank you. It's always a pleasure to be in Russia, always.
Спасибо, господа, большое.
Thank you very much. I would like to thank Irina. I would like to thank Joseph, and many thanks to all of you for being with us. In fact, we use Ribulin very actively, and this cumulative denominator of today for our clinical oncologists, for those people who use this drug in their clinical practice, very actively, in fact, very actively. In fact, everything worked very nicely, and many thanks to ASI who gave us this opportunity and supported this event. Thank you very much.